Hello and welcome back to another podcast of 1 Minute MRCP by Dr. Raza. Today we'll talk about iron deficiency anemia, that is the most common cause of anemia worldwide. The common causes are hookworm infections, and in females we have to take care of excessive menstrual blood loss as well as gastrointestinal blood loss. The common clinical findings are koilonychia, that is the spoon-shaped nails, atrophic glossitis, post-cricoid webs, that is commonly present in Plummer-Vinson syndrome characterized by dysphagia, esophageal webs, and iron deficiency. Moreover, pruritus, dry and brittle hair are the common cutaneous manifestations of iron deficiency anemia. It can also cause angular stomatitis. So the common investigation that is being done to determine the cause of anemia is the blood film that shows target cells, pencil poikilocytes. If there is a combined iron B12 folate deficiency, then there can be a dimorphic picture because of mixed microcytic and macrocytic cells. Serum ferritin is the preferred screening test. It is the most sensitive marker of iron deficiency. However, it also acts as acute phase reactant that can be grossly elevated in acute inflammation and to a lesser degree in chronic inflammation. According to the British Society guidelines, 12 to 15 milligrams per liter of ferritin show iron deficiency in the absence of inflammation, and if there is inflammatory condition, then a 50 milligram per liter of ferritin is suggestive of iron deficiency anemia. Now, a few words about treatment. So, iron tablet preparations are of three types. They can be non-enteric coated pills. That is the most common initial treatment because of the low cost. There can be enteric coated and prolonged release formulations. Delayed release and enteric coated tablets are better tolerated. However, they are less effective because they have less iron and are not released in the duodenum where iron is mostly absorbed. If the treatment is unsuccessful with enteric coated and prolonged release IRS preparations, then non-enteric coated ferrous salts are to be considered. Ferrous sulfate has more elemental iron by mass as compared to the same dose of ferrous gluconate. So the iron prescription that is usually recommended is that no iron supplement is recommended within 1 to 2 hours of antacid use because the alkaline environment reduces absorption. Acidity is required for iron solubility. Iron tablets are preferably to be taken between meals or bedtime to avoid the alkalizing effect of food and to take advantage of peak gastric acid production late at night. Calcium, phosphorus, and magnesium salts containing in iron-containing multivitamin pills impair absorption of elemental iron, so usually it is not very recommended to take a combination multivitamins for the treatment of iron deficiency anemia. Tetracyclines, milk, and phosphate-containing carbonated beverages can cause impaired iron absorption. Iron replacement in chronic renal failure is dependent on the number of ferritin. If the ferritin is more than 100, then erythropoietin therapy is to given straight away, and it is a commonly asked question in the MRCP exam. If the ferritin level is less than 100 milligrams per liter, then iron replacement becomes the initial intervention of choice. IV iron, it acts no faster than the oral iron. However, there are a few indications if the patient is unable to tolerate or absorb oral iron, or the patient fails to comply with oral iron supplementation, then IV iron is considered. Exertional angina with anemia is the strongest indication for transfusion in iron deficiency anemia. GIT disorders like inflammatory bowel disease, including ulcerative colitis and Crohn's disease, are one of the indications of IV iron therapy because the symptoms are aggravated due to oral iron therapy. So the best practice is to give 1000 milligrams low molecular weight iron dextran into 50 milliliters of normal saline within an hour without pre-medication. A test dose is usually recommended, that is 10 to 25 milligrams of iron over a period of 3 to 5 minutes prior to first infusion. If there is no acute reaction, then remaining solution is infused over 1 hour. If there is a history of drug allergy or hypersensitivity, then 125 milligrams of methylprednisolone prior to the test dose is usually given. According to British guidelines of 2011, so to correct anemia and replenish body stores, 200 milligrams twice daily ferrous sulfate is recommended. Lower doses are considered if it is effective and better tolerated, and the patient is not tolerating traditional doses. Other iron compounds like ferrous fumarate, ferrous gluconate, or other formulations like iron suspensions are better tolerated than ferrous sulfate. They are continued for 3 months after correction of iron deficiency to replenish the stores. Ascorbic acid twice daily enhance iron absorption.